We all face very challenging clinical situations where we're really just looking for tools that will help us make clinical decisions. And my research interest and the talk that I gave here at Hot Topics was really try to address that problem. And that is leverage some of the existing and emerging technologies that are becoming available to allow us to interrogate samples, biologic samples, in humans. And so what we've done is we've taken blood and urine samples from a variety of babies who are just on the cusp of getting ill and begin to look at them using some of the same technologies that have been used for newborn screening to see if we can identify molecular patterns that would suggest disease onset or disease progression. And although it's very exciting and I think we've shown some promising data, I do want to caution that it's not quite ready for the bedside. And the other nice caveat of this is that we've discovered a lot, I think, probably equally as much about the pathophysiology of disease along the way. So we start out with one set of issues and we've discovered a whole bunch of other interesting questions that we can now ask about, are these findings relevant to how the disease progresses? Next step is we need much bigger patient cohorts. We want samples that become earlier, meaning prior to the baby getting sick, and that's a very challenging problem in the neonatal intensive care unit where families are dealing already with an ill baby, and then to approach them about a study where they have a very difficult time grasping that. So some of the ways around that is to get what we're calling preemptive or presumptive consent, where we're actually approaching them before the baby gets sick because of the high risk or prevalence, so that once the baby becomes sick or the clinician suspects something, we start to get our samples. And the other big piece of that is the necessity for longitudinal sampling. Like any parameter that we use in clinical medicine, really it's not only the parameter, but it's change over time that's probably going to be most informative. And so again, it's very hard in small babies to get a lot of blood samples, and so that's why we've partnered it with stool and urine to try to combine all that we can learn from these various different matrices to identify patterns that hopefully will be informative. So congenital heart disease and other structural problems that might not be apparent when the baby is first born. It's not so much we're at the disease specificity level, really we're now working on the approach, which is can we go back in time to that preclinical, subclinical stage, and that is as soon as the baby is born, either from the blood card, possibly from the umbilical cord sample, maybe what was taking place in mom in the 3rd trimester, and what does that inform about the onset of disease in the neonatal period. I think pulling back from there, again, my answer to that would be more of a global view, which is I think there are going to be the ability to interrogate babies and other health malady or other patients with health maladies at a much more sophisticated level. I think it's going to be, for example, at the single cell level, you'll be able to take white cells, you'll be able to take a specific monocyte or a subset of T cells, and you'll be able to say what's taking place at the subcellular level in a signaling pathway that is somehow telling us about how the baby's responding or developing disease.